Hello, everyone. Apologies for being slightly late tonight. I think we've got quite a few people here, so we've a couple of minutes past 7:30, so I think we'll kick off. So good evening, everyone. Welcome. Before we begin, I'd like to acknowledge the traditional custodians of the land on which I am joining you today. I pay my respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people joining us this evening. Whether this is your first Duchenne Australia webinar following your recent diagnosis, or you've been part of the community for many years, we're really, really glad you guys are here. My name is Kathy Stalley. I am the General Manager of Duchenne Australia, but perhaps more importantly, I am also here as a Duchenne mum. My son George is 6 years old. He was diagnosed just over 5 years ago now. So I understand what it's like to sit where many of you are tonight, trying to understand what the future might look like and wanting to make the very best decisions for your child. The treatment landscape in Duchenne is changing faster than ever before. Every few weeks, there seems to be another announcement, another trial, another exciting headline. And for the first time in history, we have multiple therapeutic approaches being explored, from gene therapies and exon skipping to anti-inflammatory medicines, muscle regeneration, and other emerging treatments. It is genuinely a really exciting time. But with excitement can also come uncertainty. Families are often faced with the headlines. There's social media posts, overseas news, and conversations about treatments that can leave us wondering, what does that actually mean for my child? Is it available, and should we be doing something now? At Duchenne Australia, one of our main goals is to help families balance the hope with the evidence. There is every reason to be hopeful. Research is moving incredibly quickly. Australia's role in global research continues to grow, and more importantly, more opportunities are emerging than ever before. But while we wait for tomorrow's therapies, we can never lose sight of what makes the biggest difference today. Our strongest line of defence remains the Duchenne standards of care. High quality, multidisciplinary care, regular physiotherapy, stretching, respiratory and cardiac monitoring, appropriate medications, nutrition, and proactive management all have profound impact on the health and quality of life of people living with Duchenne. I am a big believer on focusing on what we can control. There is so much about Duchenne that none of us can control, but within our homes, we can make sure that our child is receiving the best quality care available today. We can work closely with our neuromuscular team. We can ask questions. We can attend appointments, and we can stay engaged in their care. These aren't simply things we do while we wait for future treatments. They are the treatments. They are the foundations that give every child the best possible opportunity, both today and into the future. Tonight is about helping you understand better where the science currently sits, where it's heading, and how Australian families can prepare for what's ahead. We are incredibly fortunate to have three of Australia's leading Duchenne clinicians with us this evening. Firstly, we have Dr. Ian Woodcock. So he will be joining us from the Royal Children's Hospital in Melbourne, who will provide an overview of the emerging treatment landscape. But before that, we may have to have Dr. Michelle Lorentzos from Sydney Children's Hospital Network. She's going to guide us through clinical trials, what participation involves, what families can expect, and how to prepare. And then we have the lovely Dr. Eppie from the Royal Children's Hospital, Melbourne, which will discuss the Australian Neuromuscular Disease Registry and why it plays such an important role in connecting Australian families with research and helping strengthen our country's trial readiness. Thank you again for joining us this evening. I hope you leave tonight feeling informed, empowered, and reassured, with a clearer understanding of both where Duchenne treatment is today and where we are heading in the future. So let's get started. I'm not sure, have we got Ian? Has he arrived yet? Or is it Michelle? Michelle, I think you're on mute, so I'll get you to go.
Ian's right on cue. He's just appeared.
Is he?
So.
Look at this, almost like appearing.
Perfect.
Somebody has to make an entrance, Ian.
Absolutely. I'm always needing to make an entrance. You know me.
Awesome. Oh, thanks, Ian. It's lovely to have you and welcome back to Australia. I know it's been a whirlwind for you.
Thank you.
So did you want to kick off? Do you have the slides ready?
I just about do, but
Okay.
as always is the case, just give me 1 second to
No,
try and
that's so fine.
share my screen. Right, sorry, just give me 1 sec. And then share that.
So, Kathy, shall we just mention while Ian's getting his slides up that there is a Q&A function if
Yes,
yes, if people want
there
to.
is.
I'll let you
There is
explain.
no, yeah, so there is a question function down below. We did have the opportunity for those to input some questions prior or during registration, which I have shared with the team. But if there is any burning questions, please pop that in the chat, and then I'll moderate at the end.
Can I just check what screen I'm sharing?
Your presentation screen. So
Okay.
perfect. What you've got now is perfect.
Okay. All right. Good. All
Great.
right. Thank you. Thank you very much. Sorry for keeping everybody waiting. So I'm going to talk through about the current therapies in Duchenne muscular dystrophy. So this is sort of looking at sort of current therapies currently available and therapies currently going through clinical trials. Now, there's lots to talk about, so it'll be a bit of a whirlwind, and I won't be able to cover absolutely everything, but happy to take questions. All right, so here are some of my disclosures, none are particularly relevant for today's discussion. So I'm going to start by talking a little bit about steroid therapy in DMD, and then we'll talk a little bit about other therapies in DMD, mainly in clinical trials, although we'll talk a little bit about some available overseas, and then we'll talk a little bit about gene therapy. So just to start right at the very beginning, for just to bring everybody up to speed. So dystrophin is the protein that is missing in Duchenne muscular dystrophy, and dystrophin is a protein that acts as a cellular anchor, and it links the stretchy part of the apparatus of the muscle to the muscular cell wall. And when dystrophin is missing, it means that the contractile apparatus contracts without an anchor, and so it can cause damage to the cell wall as the muscle contracts. And this results in injury to the cell and breakdown of the cell, damage, which then doesn't repair properly because there's an impairment of the regeneration and repair functions in Duchenne muscular dystrophy. So one of the so this leads to inflammation and then to sort of the loss of muscle over time. And so one of the main therapies we use at the moment, and it's still considered standards of care, are corticosteroids. Now, I know that these are not terribly popular, and I know that these are absolutely not perfect, but they are currently the best we have in Australia, and they are good, and they do make a difference. There are two types of, broadly speaking, two types of steroid we use in Australia. We use prednisolone at a dose of 0.75 milligrams per kilogram, or deflazacort at a dose of 0.9 milligrams per kilogram. Now, there are other intermittent regimes that have been used before. 10 days off, 10 days on, 10 days off, and weekend dosing, high dose weekend dosing. And the latest data is that there is not it seems to be that daily steroid dosing seems to be better than intermittent dosing, although the weekend dosing was not included in that particular trial. The exact mechanisms are unknown, but there are a number of theories. The fact that there's a positive effect on myogenesis and the anabolic effect on muscle, increasing muscle mass, also potentially stabilizing the muscle fibers, reducing inflammation and reducing muscle death is possible. It is at the moment the only medical therapy available in Australia that has been shown to be effective in Duchenne. There are another couple of therapies available overseas that also have shown to be effective in Duchenne. And so steroids generally improve the strength quite rapidly in Duchenne within the first sort of 6 to 12 weeks. We often see that children get a bit of a boost from their steroids. And it may prolong independent ambulation by a couple of years, but also more to that, more or even more important than that, is it preserves upper limb function, preserves respiratory muscle function, delays the onset of cardiomyopathy, and it delays the onset of scoliosis, which is particularly important as children go through their pubertal growth spurt, as scoliosis can become a major problem at that point. So the benefits are as I've stated, and the actual prolongation of ambulation, it can improve it by 2 to 3 years of in different studies. There are a number of different studies that have looked at different steroids and looking at different steroid regimes, and there are proponents and advocates for lots of different types of steroid regimes, and there's no one steroid or one regime that is clearly better than the others, although it does seem that daily steroids do have the edge, but prednisolone and deflazacort do seem to be equal. And this has been studied in a number of different trials, including the very first trial, which did show that there was a clear difference between those boys on steroids compared to those boys who were not taking steroids. The most data is for daily prednisolone, in which the studies have shown a benefit, but unfortunately we are all aware of the side effects, which can include weight gain and can include increase in blood pressure, can cause behavioral difficulties and challenging behavior, can affect growth and may cause a Cushingoid appearance, which is a slightly round-faced appearance that some boys may develop when they've been on steroids. The intermittent dosing regimes have been used, and I mentioned a 10 days on, 10 days off regime, which has been used mainly in the UK and in Europe, but has shown to be less beneficial than daily steroids. There are some studies that have suggested that high dose weekend steroid regime is preferable, and there are some parts of the US that strongly advocate for this. We have tried that at times in Australia, and there may be some boys who are on high dose weekend steroids. It has been shown in some of the studies to be as efficacious, meaning it works as well as a daily dosing, with hopefully less side effects. I think the jury actually is still out as to which is the best regime to be on, and this is not definitely superior to daily dosing. What we tend to do in that regime is we give the double the weekly dose of steroids, but given just over 2 days on a Friday and a Saturday. And so whereas on daily steroids, you might be on a dose of 20 to 30 milligrams of prednisolone a day, and on the weekend dosing, you might be on a dose of 150 to 200 milligrams of prednisolone on a Saturday and again on a Sunday. Deflazacort is a synthetic derivative of prednisolone, which has been shown to have a benefit in Duchenne, and it is at least as good as prednisolone. I personally quite like deflazacort. I think it seems to work quite well, and there have been some conflicting studies that may have shown deflazacort to be a little bit superior to prednisolone. I'm not sure that is clear, but it certainly has a place. A lot of the time, people will start on prednisolone, and then if there's problems with behavior or weight gain, might shift to deflazacort. The deflazacort might be a little bit harsher on bones and cataract development, but it seems to be at least as good as prednisolone in maintaining the beneficial effects of steroids. And then this was a study, the 4DMD study, which looked at a number of different regimes and did find that there wasn't a clear difference between prednisolone and Duchenne in a large cohort of prednisolone and deflazacort in a large cohort of boys with Duchenne. However, this is the study that really did show that the 10 days on, 10 days off regime was inferior to daily dosing. I think intermittent dosing does have a role. It potentially there could be a role for intermittent dosing for boys who are not tolerating daily steroids, as it may be beneficial compared to no steroids at all. These are just a few graphs showing some outcomes. The deflazacort group, the daily prednisolone group and the daily deflazacort group in the blue and orange did not really show a huge difference, but the intermittent prednisolone, which is this sort of beigey color, was inferior. Now, a number of people have mentioned vamorolone in clinic. Vamorolone is a medication, is a sort of synthetic steroid analog, which they refer to as a dissociative steroid. They think the developers feel that it has the benefits of the steroids, but without the side effects. I think it has shown benefit. It has shown that it's better than placebo. I'm still not 100% sure that it's clearly being shown to be better than the current steroids we have available, although there are some data that it does have less of an effect on some of the height and weight related issues that prednisolone and deflazacort may have. Unfortunately, the vamorolone is not available in Australia at the moment. Hopefully that will change in the future, but at present it's not currently available. Now this slide just shows that there is data to show that it does have improvements in a number of different functional outcome measures compared to placebo. There were dose-dependent improvements over 6 months in a number of different outcomes, and they all show continued improvement after 18 months. And the efficacy of vamorolone has been shown to be similar to corticosteroids, but there hasn't been a clear head-to-head study yet. I think the other important aspect of the steroids are the side effects, or the fact that steroids have to be taken every day and or taken as prescribed, should I say, and you shouldn't miss doses. If you do miss doses, then there is a risk that the body is no longer able to make its own steroids that it normally makes, and you can develop a problem called adrenal crisis, where your body can't respond to illness or infection, or it can't keep the blood pressure high enough to what it needs to. Which is important for when the boys are unwell. It might be that they need extra steroids if unwell, as advised by doctors. And it is very important that when you do stop steroids, if you do stop steroids, that you do it in a safe way and in a controlled way, as guided by your doctors, because it's very important that the steroids are weaned off appropriately, just to try and allow your body to compensate and take over. There are some care considerations. This is taken out of the care guidelines from 2018, and that there are a number of different ways of managing steroids and starting steroids and monitoring boys when they're on steroids, and what to do when the boys are no longer walking, about using steroids. The general agreement is that we would continue steroids at the same dose throughout. When they no longer are able to walk and progress into adulthood. The PJ Nikolov protocol was developed by a family of a young man, PJ Nikolov, who unfortunately was a boy with Duchenne, was on steroids and became sick or needed surgery, and went into adrenal crisis at that time, which was unrecognized, and sadly PJ passed away. And this is something which could be could have been managed better had the steroids been recognized, or had the complications of the steroids been recognized and he been treated with extra steroids. Then potentially he may have survived. And so this is where the PJ Nikolov protocol has been developed by the parent project Muscular Dystrophy in the US, and it basically states that if the boys are very unwell, then they should potentially have additional steroid dosing, and they should wean off very, very carefully. I won't go through the exact PJ Nikolov criteria today. This is something you can discuss with your own doctors if need be, and it's also available online. I just want to move on to sort of the emerging therapy side of the talk. So this is the second part of my talk, is sort of talking about emerging therapies. I'm going to go straight on to givinostat, and we'll talk a little bit about exon skipping therapies, and then we'll talk a little bit about some gene replacement approaches. Now, I have crossed out suppression of nonsense-mediated decay there, because unfortunately, despite working very hard over the last 15 years or more to show efficacy, Atalorin has no longer is no longer available anywhere around the globe. It's been shown that it's not been clearly more beneficial than the current therapies available, and the regulators have, in their wisdom, decided not to approve its use anywhere. Which is obviously very disappointing for anyone who was already taking that therapy. So givinostat, most people would have heard about. It's been developed overseas in Europe and the US. It's an HDAC inhibitor, histone deacetylase inhibitor, and it is a non-steroidal treatment that has now been approved in the USA and parts of Europe. And it helps to activate muscle repair mechanisms and also to increase muscle fiber regeneration, reduce inflammation, and reduce fibrosis. In the phase 3 study of 179 boys aged 8 to 11 years, it was found that both groups, when compared to placebo, did deteriorate, but the givinostat group deteriorated significantly more slowly. So they maintained function for a lot longer than those boys that were taking placebo. This is something which is now available in the US, is becoming standard of care pretty much in the US. A lot of the boys in the US will be starting on givinostat now. It's not being used as steroid sparing at this stage. It's being used as well as steroids. And it's just something else which is seems to be beneficial to boys. We are over here working very hard at communicating with the company to try and work out a way that we can get givinostat available in Australia. It's just taking a little bit of time, unfortunately. So there are different types of genetic therapy, and genetic therapies are therapies that are working to modify the function of a faulty or missing gene. And there are different ways that we can do this. You can use antisense oligonucleotides, or we can use gene therapy. And antisense oligonucleotides are very small bits of genetic material that can bind to the DNA and can affect how the DNA is read. And there are two main ways we do this, a PMO and a 2-MOE backbone, chemistry backbone. And the PMO is the most commonly used for the different mechanisms that we see. And there are various different therapeutic approaches to use antisense oligonucleotides. In Duchenne, we tend to use it for exon skipping, which I'll talk about in a minute. We've previously tried using a novel ASO to target a specific form of a white blood cell to try and reduce inflammation and fibrosis, which unfortunately was found not to be beneficial. And in spinal muscular atrophy, we use it to upregulate one of the genes to produce the protein, that's the missing protein. And there are other disease groups that are looking at different methods of using antisense oligonucleotides. But for Duchenne, we use it as exon skipping. And so to understand exon skipping, I first need to explain the reading frame analogy. So if you see what's on the screen here, and just a simple sentence, the big red dog ran and sat. Now, there are lots of three-letter words there. And the reason for that is because the spelling of your genes is done in three-letter blocks. And this is important because if you had that sentence and we removed one of the letters, then that no longer makes that sentence no longer makes sense because everything shifted one letter to the left, and so no longer makes sense. And so the reading frame has been shifted. So that is what happens in Duchenne. However, if it was actually a word that was missing as opposed to just one letter, then although it no longer reads the original sentence, it's no longer the big red dog ran and sat, it's now the red dog ran and sat. but that's the reading frame is maintained. And that is what we see in Becker muscular dystrophy. And so the goal of exon skipping is to turn Duchenne muscular dystrophy into Becker muscular dystrophy by removing the B and the I from that first sentence to make the reading frame, or to restore the reading frame. So to go through this again in a pictorial form. So this is what the DNA and RNA look like in an individual who does not have Duchenne muscular dystrophy. So their gene looks like this. With we're looking at the exons there, and we're looking at exons number 47 through to 53. And so you have the DNA, which looks like the top line in orange, with exons 43 to 53. You have the pre-mRNA, which it's in red, and then you have the RNA, which actually is going to end up coding for the protein, in green. In Duchenne, if you have a deletion of exons 49 and 50, then as you can see there, the pictures and the blocks there no longer match up, and so you have a shifted reading frame. And as the reading apparatus gets to exon 48, it then can no longer read any further, and so you don't get the protein produced. And the idea of exon skipping, if we're taking exon 51 as the example, is we remove exon 51 and we end up exon 48 and 52 can match up, and so we are restoring that reading frame. And so you go from exons 47, 48 straight through to 52 and 53. And so the reading frame is restored, and hopefully a shortened version, but hopefully a functional version of the dystrophin protein is produced. There are a number of patients that can be amenable to different skipping mechanisms or different skipping methodologies. So, for example, in the hotspot, which is between exons 43, 44 to 55, then you could skip exons 51, 53, 44, 45, 43, 46, different, and the number of boys who would be able to benefit from such a treatment is shown there, 14%, 10%. In total, up to about 50% of boys. So that does unfortunately doesn't cover everybody, it only covers 40 to 50% of boys. Unfortunately, the first generation exon skipping results have been somewhat underwhelming, with eteplirsen or Elondis 51 being approved by the FDA, and they actually only restored dystrophin a tiny amount, from 0.16% of normal to 0.44% of normal. Goldersin has done similar to just over 1%, exon 53. Vitalarsen had a bit more of a increase to 5.7%. And casimersen as well had a small increase in the amount of dystrophin produced. Now, eteplirsen was the first one studied and the first one approved by the FDA. That did show some improvements, as I mentioned, a small amount of dystrophin improvement, but it showed a little bit of a benefit compared to a historical control in the 6-minute walk test, but it didn't show a huge amount of improvement, but it was enough at the time to be approved by the FDA. However, it's not available in Australia, and nor will it get approved in Australia because the benefit is not enough. However, the main problem with the first generation antisense oligonucleotides, such as eteplirsen, is that it doesn't get into the muscle terribly well. And so when they talk about a naked PMO or naked antisense oligonucleotide, that is the antisense oligonucleotide on its own, it doesn't get into the muscle very well. However, a few companies have found out that if you combine it with something, then it can get into the muscle a bit better. And so companies are looking at what we call antibody conjugates, which is where they attach that antisense oligonucleotide onto an antibody or something else that's going to be enable it to cross the barrier into the muscle better. And so there are a couple of companies that are looking at this. So Dyna are one of those companies that's looking at exon 51 skipping. And potentially by combining it to an antibody that binds to the transferrin receptor on the muscle cell wall, then it could get into the muscle much better. And the study is ongoing, but early signs are that it does improve the amount of dystrophin. It does increase the amount of dystrophin significantly, and it does also improve functional outcomes as well compared to placebo, which is good. So we'll wait and see how that progresses. Avidity is another company. They're looking at exon 44 skipping, a similar transferrin receptor, and their data has shown that they have increased dystrophin quite significantly, up to 25% of normal, or up to 58% in adjusted muscle weight. They found that there was functional improvements in the 4-stair climb, the 10-meter walk run, and the time to rise from the floor. Now that is that's a phase 2 study. There's a phase 3 study just starting up, which will be recruiting in Australia later this year, specifically for boys who are amenable to skipping of exon 44. Muscle regeneration is another option that's being looked at, and that is trying to actually improve muscle repair and regeneration with a hope of improving strength. There is currently 3 companies looking at doing trials later this year or next year to develop this. Satellos is a company that's currently recruiting in Australia, and Keros Therapeutics and Juvena are looking to have trials probably end of this year or next year to try and improve muscle regeneration. Now, the final part of my talk for the last 5 minutes or so is just to quickly go over gene therapy. Now, there's a lot more to cover than I'm able to cover in the time I have, and so I'm just going to skim over these slides really quite quickly. The main thing to know is that it can't be a cure, because we cannot fit the whole of the dystrophin gene into the delivery vehicle. Now, the dystrophin gene is very, very big, where the delivery packaging capacity is about a third of what the size of the DMD coding sequence of the gene. So researchers have created what they call microdystrophins. Now, what are I'm just going to skip through these slides, just really talk about the Duchenne trial. The important thing to be mindful of is this, and I'll come back to the microdystrophins in just 1 second. There are 3 key components in gene therapy. There is the gene that we want to give, which we've talked about, the microdystrophin. I'll come back to that in a second. There is the way of delivering the gene therapy to the cell, which is a vector, which in most cases at the moment is a virus with all the viral innards taken out and replaced with the transgene that we want to give. And there's a promoter, and the promoter is important because that actually tells the gene to start producing this protein once it's in the body. What happens is we deliver the gene into the vector into the body, carrying the gene. It gets into the cells, and then it starts to produce it produces its protein as it sits outside of the chromosomes as a extra chromosomal episome, which then produces its own protein. And the important aspect of that is that it sits outside the chromosome, and so it doesn't integrate into the host's genome, which is an important safety mechanism, and that's particularly important for AAV vectors. Okay, so this pictorially is going to show the difference between the full-length dystrophin, as pictured here, and the microdystrophin. Now, the idea of the microdystrophin is it still has all the components it needs to be able to anchor the stretchy apparatus of the muscle to the cell wall, and so it can still have the same benefits of anchoring the stretchile apparatus to the cell wall and prevent contraction-related injury and damage. So you will have all heard that the FDA has approved the Elevidys of gene therapy in the US. The rest of the world, apart from the Middle East, has been slow to roll this out, and for a number of reasons. It's still not approved in Europe either. And the main reason is because the studies didn't achieve their primary endpoint, which was changing the North Star ambulatory score, which is something all your boys will have measured every 6 months or so in their clinics. It did not improve that over a year. And there's various reasons why that may be. It might be that the North Star is not terribly responsive to change, but over 12 months it didn't show a change. However, the reason it got approved in the US is because in some of the secondary outcome measures, including the time to rise and the 10-meter walk run test, it did show a difference between those boys treated with Elevidys and those boys who remained on placebo at 12 months. So the first one there changed with Elevidys in the boys who had taken Elevidys in the red and the placebo in grey. You can see that there's a slight difference in their time to rise, and again a slight difference in the 10-meter walk run. And the other way, the other information they gave to the FDA was they showed that all of their functional measures, barring the North Star and the 100-meter walk run, did show a benefit towards treatment with delandistrogene moxeparvovec or Elevidys. And this data has actually gone on in the 2 years and 3 years to show that there has been a difference between the two groups at that point. Now, I'm pretty much out of time. So just to say that there are risks associated with gene therapy, which we monitor for very closely. Vomiting, nausea, fever, and reduced blood platelets in the blood are almost universal. But there can be some other more severe side effects, including a cardiomyopathy, which is where the heart gets inflamed, and or kidney-related injuries or liver-related injuries, all things that we monitor for very carefully. And I think it's very important, and this is a slide I have borrowed from Michelle, and it's very important to think of this as not just a simple one and done treatment, but it's more like a stem cell transplant that requires a lot of careful consideration and a lot of monitoring afterwards. There are a number of different companies in the gene therapy space at the moment, with Sarepta being the one that's got the approval in the US, but also Solid Biosciences and Regenerex Bio also having clinical trials around the world at the moment. And Solid is hoping to have I think is currently enrolling a trial around the world in which Australia will be a site. So in summary, corticosteroids remain current standard of care for Duchenne. Pred and deflazacort are pretty much equal, but daily is better than intermittent dosing at the moment. And there are multiple other approaches in development, and the second generation exon skipping looks promising with good results in trials so far, and trials are still enrolling at the moment. The likelihood is that in the future it won't be a single therapy that we need. It will likely be a combination therapies, but that will obviously be taken into account by different regulators in different jurisdictions. And more gene therapy trials are ongoing, and hopefully with the new vectors will be even better than the previous ones. So thank you very much. And I will happy take questions, but I think I'm a little bit over time.
That was incredible. Thank you, Ian. Yeah, that was a lot that you've just covered in half an hour. So well done. Guys, I'll just say that we've had a technical issue, so we don't have a question box, but I have changed my little naming platform down below. So if you want to email me any questions, and then I'll moderate and answer them at the end. So you can see below, Kathy@DuchenneAustralia.org. Please send me some emails if you have questions for Ian, Michelle, or Eppie once they do their presentation. Thank you so much, Ian. That was amazing. So now we will go over to Michelle, who's going to take us through sort of a more generalized look as to what clinical trials actually are, and what they look like in sort of real life.
Thanks, Kathy. I just couldn't find the ability to unmute once I'd shared. So now I've mastered that. Let me we'll go back and share okay. So can you see my slides? I'm assuming
yes, we can.
Wonderful.
We can.
Okay. So good evening, everybody, and thank you for making time on this wintry, what day is it? Tuesday evening, to talk about Duchenne clinical trials within Australia. And I definitely think Ian had the hardest job there in running through all of the therapeutic landscape for Duchenne. There are conferences that run at 3 or 4 days and have trouble squeezing all of that information in. So I know that's a lot of information that you've just been presented. My talk is going to be probably a little more brief, but also, I guess, less caught up in all of the scientific concepts and graphs. So I guess I'm inviting you to take a breath, and I'm going to talk a bit more about what clinical trials actually mean and what involvement in clinical trials looks like, and a little bit about the therapeutic pipeline in terms of how something goes from being a clinical trial to eventually something we can administer for patients. Now, I often like to start, I will also, just like Dr. Ian Woodcock just mentioned, disclosures. So for those of you who don't go to these kinds of presentations often, we always think it's important to tell you who we are, but also associations we've had with different clinical trials or companies. Not because it's changing anything that I'm going to say today, but I think people have the right to understand that we do work on a number of trials with companies. So for me, I'm a clinical doctor. I'm a pediatric neurologist. I'm based in Sydney, and I work at the Sydney Children's Hospitals Network, mostly at Westmead, but I do have a role at Randwick as well. And I run quite a lot of clinical trials around Duchenne muscular dystrophy. So how that works is that generally companies who are making the drugs will ask us at the hospital to become a site. And when we conduct activities around those clinical trials, the company pays the hospital so that we are reimbursed. So there's no profit making from the hospital, but the costs of running that trial, so providing medical input, for instance, doing blood tests, looking at the data, is covered. So none of that money goes personally to me, obviously, but then I do sometimes provide input to scientific advisory boards, which might be from companies or not-for-profit organisations, and sometimes there is a fee that's associated with those. So none of that influences what I'm going to say today, but it is standard practice when we give a talk as clinicians and scientists and researchers to give that information so that people feel that it's all been transparent. But what I really want to talk about today is some important points around clinical trials that I think we owe it to our families and parents and patients to speak about, and a little bit of information that might be useful if you're thinking about being part of a clinical trial. So just to give you a little bit more context about myself, as I mentioned, I'm a pediatric neurologist. Duchenne muscular dystrophy is my particular main clinical interest, but I do work across lots of other neurological conditions. My main role actually these days is working as something called the medical lead for our Kids Advanced Therapeutics program, which we have in Sydney. And that's a program that was set up about 5 or 6 years ago, acknowledging that therapies for conditions in children are now becoming more complex. And thank goodness we are now seeing a change in treatment landscape where there are specific gene and cell therapies that work for particular conditions, or where we're seeing potential of them working, either in the lab or clinical trials, and that we wanted to make sure that Australia was at the forefront of that. So we've set up a platform called the Kids Advanced Therapeutics Program, and I'm the medical lead of that, which means I work across gene cell therapies, ASO therapies for lots of different conditions. But as I said, my particular clinical interest is Duchenne. And I also just wanted to mention that myself and Dr. Ian Woodcock and Dr. Eppie, who are on this phone call or webinar today, are very well linked with the broader international community about Duchenne. So we frequently, in fact, Dr. Woodcock today has just flown back from the international conference. That one's on FSHD, but we do attend international conferences in the DMD community. I'm heading to the International Congress of Neuromuscular Diseases next week, which is held in Europe. We frequently get asked to speak at these conferences or present posters. And so the information that you're receiving today is at the cutting edge of what's being discussed within that broader international spectrum. And the final thing that I wanted to say is acknowledging that I can imagine, and I have 2 kids myself, but none of them are affected with Duchenne. But I as a parent and as a person who finds sometimes decision making about medical things can be quite stressful. And also I work with many families who have been affected by Duchenne. And over again, one of the things that I'm aware of is that the decision making, the uncertainty, the stopping and the starting, hearing about treatments that may be effective and they turn out not to be effective, or treatments that might come to Australia, but we don't know when they're going to come. We recognise that these are stressful conversations. And so it's great we can have this webinar this evening, but I'm also mindful that It's important that people take care of themselves. You can certainly reach out to your clinical teams, to your personal supports, people like your GPs if you need to speak more about your own psychosocial, or I guess the burden of this information and the decision making, and that we recognize that it's stuff that carries a weight. But I also know you don't want me to just rabbit on about, thoughts and feelings, and you want some information. So I'll move on. And one of the things that I wanted to talk about when we think of clinical trials, and Ian kind of covered that really with his spectrum. I like to break it into kind of simple ways of thinking that if you're doing a trial in a genetic condition, there's three main things you can do. You can try and change the gene, and that's what those gene therapy treatments do. You can try and change the way the gene is expressed, and that's what those exon skipping treatments do, where you're saying that you're not changing the gene, but the way the body reads that gene to make proteins. Or you could try and manage the symptoms that the genes cause, and that's what things like steroids do, vamorolone as well, or even givinostat, where you're looking at kind of inflammation around that results as a downstream effect of the gene. And so we do clinical trials that work across various issues. And I think many of us think that even in the next few years, it may be that you need to work on multiple parts of that pathway to get the optimal outcomes in boys and young men and men with Duchenne. So how do clinical trials fit into all of this? Why don't we just develop the stuff in a lab and then kind of, if it looks like it's working, just give it to people, which would expedite this process? Because actually, I mean, when you think about how long it takes for clinical trials to become treatments, it's getting better now. But as of only a decade ago, a treatment that was developed for any rare condition in a lab would often take up to 17 years before it actually got into, a pharmacy or a hospital and could be delivered. And that's too long, and we all agree with that. But one of the reasons that we run clinical trials is because we want to make sure that the treatments that are given to people are safe and that they work, and that we understand how we have to use them. So a clinical trial isn't simply experimenting with a treatment. It's set up around a lot of particular questions, and particularly the questions are usually going to be concerned with how safe a treatment is and how effective it is. And that generates evidence that allows it to progress further down a path. And so we have clinical trials because we want to work out, do new interventions work? And even if they work, how do we know how much of them to give? How long do you need to give it for to start to see a benefit? And is it safe? And also, is it for everyone? So we know, for example, in the gene therapy clinical trials, that the effects on the younger boys seem to be different than the effects that we might see on men who have Duchenne, for instance. And so working out, even if it works in one cohort, can you actually translate that to the others? And it's different from standard care. So when a doctor says to you, well, the standard care that we're aware of might be physiotherapy and some splinting and stretching, but also steroids, and maybe for some of the boys who are a little bit older, it might be using an ACE inhibitor, which is helpful for cardiac function. Those are treatments that have existed in clinical trials and where we say these are standard cares, and we generally have a better idea about benefits and risks, and we understand who they're for. With clinical trials, we don't know those things, and we're focusing on a particular research question that's defined at the start of the trial. Now, this isn't to say that standard care is always certain, because you would all know that your either yourself, if you're a patient, or your kids, or people you know might respond differently to treatment than, say, another patient with Duchenne, and there'll be sometimes a clinician may have suggested something to you and you go back and say that doesn't really work at all. So uncertainty is certainly part of the art of medicine, because we're dealing with human beings and they are complex. But with clinical trial, we know that there's a huge amount of uncertainty, and that affects the way we make decisions and what we recommend. So generally what happens in a clinical trial is that we will ask if we're running a clinical trial in Sydney, or they're run in Melbourne and they're run in Perth, we will be asking for the clinicians around the country to refer patients to us if they're interested in a particular trial where we think that those patients may be eligible. And then you go through a screening process where you decide based on very strict criteria. So that's not just the opinion of the person running the trial, but very strict criteria whether a patient is eligible. Then you do something called a consent, which is essentially making sure that the patient and the person who's responsible for the patient's medical care, so often going to be a parent with children, consents. And that's not just, yeah, this sounds like a good idea, but it's really important that that's governed really well and that people don't feel pushed into it, they don't feel rushed into it, that they feel very informed about the treatment and the other options. And I'll come back for that. Then usually there's a period of doing some measurements and assessment, then there's a period of giving the treatment. And that could be for as short as 3 months or even 6 weeks in some trials. It could be for as long as 2 or 3 years. Or for gene therapy, you might only get the treatment on one day, but there's a whole lot of follow-up treatment that you might need and monitoring that might go on for several years. And then we follow that up as part of the clinical trial. And how often you might be seeing a doctor or a clinical trial team for follow-up is also going to be specified in the trial. So you'll hear me talk about uncertainty a huge amount in this space because I think it's one of the most difficult aspects of clinical trials for everyone to come to terms with, particularly patients and families. Also for families where their child may not be eligible and they're kind of trying to navigate what's going to happen next. Will there be another trial with other criteria? It's also it's a complex area for us as clinicians because we like to be able to be experts and tell our patients and families what's happening. And in this space, often you can't. So specifically, I think this is really important to understand that a clinical trial, whilst we all hope that it's going to be benefit, they may not work. And in fact, they may work in one child or person and not work in another child or person. And in fact, they could make things worse. So they might have unexpected side effects or unknown side effects. And sometimes we might not discover that for several dozens of patients in. So in the gene therapy space, for the Sarepta gene therapy trial, there had been, several hundred patients had received that gene therapy before there was a fatality in a patient further down the track. So uncertainty is important to understand around side effects. But also, even if we do a trial that works in, say, 12 patients, it might be that, we know that we think it works in that group. But then when we do it in a later study where there's 200 patients, we might find that actually it just seemed to work by chance in those 12 patients. And one of the other aspects around this is that sometimes you don't know whether your child's getting the treatment or placebo. And placebo means that we give something that looks, feels, may taste if it's oral, like the treatment, but it isn't actually a treatment. It's a not the best way of saying it, it's a fake version of a treatment. And we do that because the power of knowing that someone's getting a treatment or a trial can be so great that if we don't have a placebo group, it may be that we assume the treatment's working just because it kind of plays a psychological game on us where we think it's working. And I know for myself, sometimes if I've got a really bad headache and I take a Nurofen, within a minute, I'm like, oh, that seems better. And it's actually, it can't have worked that quickly, but because I've taken something, I'm already feeling like I'm improving. And this has been borne out in so many studies to show that that's a real phenomenon. And so often what will happen is in a clinical trial, if you're really trying to see how effective it is, you do have to have a blinded trial with a placebo. There's ways around the ethics of that. So sometimes what happens is you might give some patients the treatment and some patients placebo, and it might be for 3 months, and then it might be that everyone gets the treatment. For gene therapy, there are trials where some patients get placebo and patients get treatment the first time around, and then maybe 18 months later it swaps and no one knows which is which. But all of that would be very, very, very clearly presented to you before you decide to take part in the clinical trial as to whether that's something that you want to be part of. And one of the other hard parts in this space, and this has been particularly the case for some of the limb-girdle muscular dystrophies, is that sometimes companies will want to conduct a trial because they have a treatment that they think's going to be successful, but then things change and the signal from safety doesn't look great. The company itself is losing money. They can no longer continue running that clinical trial, and the trial stops. Or the drug is shown to be ineffective pretty early on, and the company realizes that it's not safe and fair for patients to be getting a treatment that everyone can see can't work, and they also can't justify spending the money on the trial, and it will stop. So we do see clinical trials start, stop, start again, change, and that can be really hard for patients and their families. And we do try and hold companies to account to make sure if that's happening, that we know with as much notice as possible, and we think about what's going to be the follow-up plan for our patients. I don't need to go into this in too much detail, but I do think some of the terminology we use is important because you will often see things reported in the media, or if you're on social media, or doctors may talk to you about a phase 1, phase 2, phase 3, phase 4 trial. Basically, the earlier the phase, the smaller the trial in terms of patients, And the more it's really focusing on how safe is this particular treatment. So a phase 1 trial might typically be what we call open label. So everyone's getting the drug, no one's getting placebo. It might be, say, 10 boys or 10 young men. And really, when you're doing something that small, you really can't say how much it's working, and especially a condition as complex as Duchenne. So that's really saying, is this safe? And there's good reason why over time people have said you should start that way first, because we don't want to start giving a treatment to 500 boys if we don't even think it's safe. We need to have kind of really close monitoring of safety. And then as you get further along, so particularly phase 3 trials, that's usually a trial where we're saying someone's established already on in a phase 1 or phase 2 trial, this is safe. Now we're actually looking to see, does this treatment actually work? So we need more people, and we often need a more complex trial design, maybe with that placebo group. And the other thing I want to talk about is eligibility criteria, because this is often something that is quite frustrating and painful for families and communities to navigate, and even us as clinicians. And I always remember a few years ago when I started working in clinical trials, calling a mum about a particular clinical trial that might be relevant for her child. This family didn't have Duchenne. It was a different neuromuscular condition. And I said to the mum, there might be a trial. Do you think you would be interested in finding out more for your child? And she said, yes, but I would certainly want to take the medicine myself first and make sure nothing bad happens to me. And I remember thinking at the time, there's absolutely no way in the world that we can do that from an ethics perspective. No one would allow that to happen from a clinical trial perspective, from a hospital perspective. But then I thought, as a mum, it makes good sense, because when I take my kids somewhere and I'm ordering them a hot chocolate, I want to check it's not too hot for them, or if I'm not sure that food might seem a little bit off, I might taste it before I feed my kids. So those instincts to protect our kids and check it out first, it makes complete sense. But in actual fact, for a clinical trial, it's defined by very strict inclusion-exclusion criteria. And that might include, obviously, that the child has the condition, or the young person, I should say, or the adult. It might even be down to the variants that are going to be included as part of the clinical trial. It might be that they can't have had certain treatments before, or more likely, if they have had those treatments, then you have to wash them out. In other words, it might have to be 3 or 6 months of not having those treatments. And then it's things like, do they have other conditions that might actually make this clinical trial dangerous or make the results hard to interpret? And so these are really important things to think about. And this is just, I've got a few more slides, but in summary of that particular area around making informed choices about consent and about eligibility, it's important to discuss those issues with your treating team and clinician. And I should have said at the beginning, actually, that whilst we're very happy to take questions that come through to Kathy, this forum and myself and Dr. Woodcock, Ian and Eppie, we are probably not the people to be asking specific questions about your child's variant and clinical trial eligibility. They are much better addressed to your treating clinician. And if they would like advice, they can certainly reach out to us. But it can be difficult to advise around your child's eligibility for a particular clinical trial when we don't have their whole picture. So a few things just quickly why someone might want to be in a clinical trial. And one of those reasons is because you are getting potential access to a new intervention. And one of the reasons is because, we monitor things very closely. Often one of the main reasons people tell us they want to be part of a clinical trial is because, there's a lot of challenges in having a person in your family who's unwell or has a medical condition. And part of being able to take that challenge and contribute and give back is something that people often talk about as being very important to them. And also because they can, there is often some hope that it might actually improve symptoms or stability as well. But there are also reasons why some families make a very valid decision that a clinical trial is not for them, or a certain clinical trial is not for them. Often it might be around the fact that there are risks that are unknown, or the side effects. One of the side effects of gene therapy, for instance, is that once you've received gene therapy, you then have antibodies to the virus that we use to give gene therapy, which actually means that that person isn't eligible for any other gene therapy. And in fact, at the moment, someone who's received gene therapy in a clinical trial or for treatment isn't eligible for any other clinical trial. That's one of the most significant decisions that people are often facing when it comes to gene therapy. Often there's some invasive tests that might be blood tests, that might be MRI scans. In Duchenne, there's often a need to do a muscle biopsy. In fact, there's often a need to do 2 muscle biopsies, not for all trials, but for most. Depending on the treatment, it might mean that you need to come to the hospital every week or every 4 weeks for gene therapy. Your child is, or young person is generally going to be admitted for a period of time. Some people really don't like the idea of placebo, the fact that they're going to go through this process and have a period of time where there'll be absolutely um, no treatment benefit. And that's a very valid decision as well. And sometimes the emotional pressure and stress can be difficult. And one of the reasons people often find clinical trials stressful is, the effect that it might have on school, siblings, particularly if you have 2 people in a family or more than 2 even affected by Duchenne. There might be one person that's eligible for the trial and the other isn't. There's waiting around for eligibility. And obviously the fear about making a decision and not knowing what the outcomes will be. And so those are certainly things that are very real and valid. All of us working here in Australia in clinical trials for Duchenne, very much believe that we need to support the family and the child from a psychosocial perspective, and we can get social work involved. We can make sure that people are looking after their psychological health. And so it's not as though we would leave families alone with these stresses, but we can't mitigate them entirely. So being conscious of that is really important as well. So I've talked a little bit about eligibility, but the main things in terms of thinking about your child or young person would be whether or not they have the correct diagnosis, the genetic variants, the age, other treatments, the stage of their condition. So some trials are looking particularly at early stage Duchenne, some are looking at later stage, and so it might be that the trial needs to have patients walking a certain amount to be part of that trial. Or it might be, in fact, that they are only recruiting patients who are not walking and who have been non-ambulant for a period of time. And one of the reasons that they do this is partly to make sure that you're targeting an area where we think the treatment is going to be safe. But it's also because in order to say if it's working, we need to have started people who are at a similar baseline together. And otherwise, it's hard to actually find out whether or not the treatment has an effect. And that's kind of summarized in this slide here, but I won't go through that in too much detail, just in the interest of everybody's time this evening. One of the challenges can also be that sometimes these clinical trials have very small numbers of places. In fact, I can recall one gene therapy trial we did a few years ago for younger boys that had 10 spots in the world. And that can also be stressful. I would reassure people that certainly Australia, from the clinical trial perspective, is very involved in many of the clinical trials around the world in Duchenne. In fact, I would say by far most of them. And we are often one of the earlier sites for clinical trials. So even in one of the recent clinical trials for gene therapy, many of you may have heard of the Solid Biosciences trial. The first patient in that phase 3 trial to be dosed was an Australian patient. So we are certainly keeping pace, but that doesn't mean that we have endless numbers of spaces. And so again, having a think about and being aware of that is important. At the same time, one thing that I think that counters the concern around missing out on a spot is again the reminder that we don't know how safe or effective treatments are when they are clinical trials. And so I've certainly had patients who've missed out on clinical trials previously and been disappointed, only to find when the results of that trial came out that actually maybe they felt that it could have actually been a decision that worked in their child's benefit not to have been on that trial. But we recognize that this uncertainty is still difficult for people. Some of the questions we sometimes ask is why certain trials aren't available in Australia, which is a very reasonable question. There's certainly been an increase in acceleration of clinical trials coming to Australia, but sometimes companies that are based in the US or in Europe, particularly if it's a small clinical trial, like an early phase trial, may decide to keep the trial close to where they're manufactured because it's cheaper. Some trials only want to work in one site. And so one of the aspects of work that we do is obviously making it very clear what our capabilities are in Australia. And we have very robust processes around ethics approval. We're quite quick in how quickly we get trials started up once they've been approved. And generally, it's something that has been increasing a lot in the last, I guess, 5 to 7 years, has been our presence in the clinical trial space. And I think one of the other really important aspects to think about is how we get a balance between the hope. So I would absolutely say very authentically that the acceleration of research in Duchenne in the last 3 to 4 years very much excites me. And there is real hope that we are seeing both in terms of gene therapy as well as some of the exon skipping treatments, ways of getting these treatments into the muscles that are far superior than what we've seen previously. And I think it is a time to be hopeful and optimistic. Having said that, we don't have a cure. And even when we find treatments that are effective, they may not be, they may have their limits, and their side effects. And so I think kind of holding that space of being hopeful and optimistic, but also ensuring that we are not causing further distress to people by taking part in a hype that then leads to this incredible emotional roller coaster and devastation. I think that's something that's really, really important. Sometimes it can be tempting to get excited about a good signal that we see on a clinical trial and say how wonderful the treatment is, and certainly celebrating those milestones is important. But sometimes it can get carried away where people start, suggesting that these treatments are curative, and that can be really hard, particularly when those treatments are not necessarily in Australia. So certainly the exon skipping drugs that have been approved in the FDA, none of those results are very exciting. And when I speak to my colleagues in Europe and the US, many of them are not recommending those weekly exon skipping infusions to their patients because the benefit of the treatment may be non-existent or so small compared to the burden of having to attend a hospital every single week for an infusion, when a drug may not be making any difference. So there are lots of questions to ask if you're thinking about a clinical trial, which I've put up here, which you're welcome to, I guess, take a shot of these questions. So why is the study being done? What phase is the trial? Which gives you an idea of how much uncertainty and evidence there is that already exists. What are the possible benefits, risks, or side effects? And the possible benefits, even things like sometimes I've had families where their young person has not walked for several years. And really, none of the treatments that are certainly in the pipeline today are suggesting that if you've been not walking for 5 years, it's none of the treatments in the pipeline are really looking likely to make that person get up and walk again. Most of what we're talking about doing in terms of treatments for Duchenne is stabilizing the clinical course, or perhaps having some small improvements, which is fantastic. And certainly if something comes along that can reverse all that muscle fibrosis, we would all celebrate it. But we want to make sure that when a family agrees to be part of a clinical trial, they have realistic expectations about the best case scenario and also about the harder things that could happen. And also, if you don't go on a trial, what are the alternatives? And then all the practical stuff, like how many visits and what happens if we pull out of the trial, which people are welcome to do from any trial. But obviously, if you've received a gene therapy, hence my slide about things like transplant, you can choose to get off the trial, but you can't take that gene therapy away. Once it's been given to a patient, it stays with them. And I think we're seeing now, I suppose, not only optimism around the technologies that are going into these treatments, but how we might actually be able to make clinical trials themselves more innovative. So you could be looking at several treatments at once on a trial, for instance, or making it easier to do clinical trial visits from home. And there is a lot of work being done in this area, which I think is also positive. I guess my last thing, this is my last slide, and then I know Eppie is also going to be speaking about the registry. I think one thing that I haven't mentioned, but I realize is probably an oversight, is just to say, once clinical trials have been done, how do they then become drugs on our formulary? And so what then has to happen is once the clinical trial demonstrates some benefit and safety, the company who's made that product will apply to the regulatory body. So in Australia, that's the Therapeutic Goods Administration, or TGA, for approval. That process takes time. And what that doesn't do is decide who's going to pay for the drug. So once that's been approved, or I believe in parallel, they can actually do it now in parallel or at the same time, apply to something called PBAC, which is the pharmaceutical, sorry, it's late in the evening, who actually oversees the pharmaceutical benefit scheme and says, will the government pay for that treatment? And for things like gene therapy, that's a significant hurdle because the treatment itself is about $3 million. And so even once the clinical trials are in existence, there is often going to be a delay in terms of getting that through TGA and also onto the PBS. And the other aspect of that people sometimes want to know about is that for sometimes those drugs that only work for a small number of patients, like the exon skipping drugs, sometimes it can take some advocacy to convince the companies that they do want to apply for access in Australia, because that takes time and expense for them. And so one of the certain advocacy pieces that many of us in the clinical space are doing is when we're working with companies on clinical trials, we're actually saying to those companies, if we participate in these clinical trials, we think it's very, very important that you then apply for approval if that drug is shown to be effective, and encouraging that process. It's actually not something we can enforce, and we don't want to make it hard for companies to do their clinical trials here, but we are aware of that frustration. It frustrates us as well. And we are certainly in conversations with both the TGA and with companies around working out how we get, I don't want to get treatments that don't work onto our system, but the treatments that work onto those systems. Look, I hope that's all been helpful. I know it's lots of information, but I will hand over now because I'm sure there's more things to get through. So thanks, Kathy.
So helpful. That was amazing. I've had a few people contact me just to say that was so insightful. Such a well-rounded prezzo, like so many things for families to think about. I was actually thinking back to when George was first diagnosed, and you go into that real zoom in on like what clinical trials are available, how do we get them here, how do I get him on it? And then someone actually described it to me and mentioned the word, they said it's actually, you do realize it is a human experiment. So it is something to really consider, when you are considering or eligible or looking at these clinical trials. There's a lot of different aspects to consider. And I think your presentation, I hope people were screenshotting, but hopefully I can get a couple of those slides as well and we can share them. So that was so good. Thank you, Michelle. And now, last but not least, we've got Eppie, who's going to give us some insights into the Australian Neuromuscular Disease Registry, which is super important to make sure that our data is there for when these pharma companies are looking at Australia for trials. So, Eppie, I'll let you take it away.
Thank you, Kathy, and thank you, Michelle and Ian. Always wonderful talks to hear. My talk is short. I'm going to talk about the Australian Neuromuscular Disease Registry, why it's important, and as Kathy says, its implications for clinical trial readiness for our country and bringing trials to Australia and other things. So, Kathy, can you please confirm you can see my slides?
Yep, they're perfect.
So, thank you for listening late into the evening, particularly on the East Coast. My name is Eppie Yu. I'm a paediatric neurologist and I work at the Royal Children's Hospital in Melbourne with Ian. And the main disclosure that I have for you is that I'm the principal investigator of the Australian Neuromuscular Disease Registry. You might see in the presenters' names, Melissa D'Souza, she's our program manager, also joining tonight. If anyone has any other specific questions, we can always follow up later. As Michelle mentioned, a lot of us do trials. We have funding and research support and speakers, advisory board honoraria, which again don't come directly to me, but I think agree also very important to know. So the first thing that happens is you mention the word registry, and I think people immediately assume it's really boring and irrelevant. So I'm going to challenge that in the next 10 minutes and essentially talk about why registries are important, particularly in the neuromuscular space, and particularly for Duchenne muscular dystrophies, where there's so much happening, as you've heard from Michelle and Ian, in new therapy development and maintaining best standards of care for our patients. So our registry is the only national registry for children and adults with genetic neuromuscular disorders, and we are part of a very big alliance called the Treat NMD Network. And this is a global network of multiple patient registries for neuromuscular disorders around the world. And I've got a map of the world in a minute, and you can see how important this is and that the power of what happens when you bandy together and share data, because data is actually very, very powerful. And you can see here we have lots of partners, lots of different patient support groups who we work really closely with to try and maintain interest and recruitment into the registry. So what do we do in the registry? Why are we doing it? So as you would in a registry, we collect data on clinical factors, genetic diagnoses, genetic mutations, and information about the demographics of patients who have neuromuscular disorders in Australia. And the term that's often used is real-world data. So we've talked and heard a lot about clinical trials this evening. Clinical trials with all the strict inclusion and exclusion criteria that you've heard from Michelle are not really what happens in real life. And so once you've been through the clinical trial process and you get into the real world, the drugs are shown to be effective and enter the market and are available, for example, in Australia on the PBS, that's real world. Then we see actually what really happens in a broad group of patients, not the very narrow range that the clinical trial has included to study. The registry is a great way to facilitate clinical research and to collaborate with not only national but also international investigators, particularly within this TREAT-NMD network. And it's because all of the neuromuscular disorders that we see in our clinic are individually rare. And so when you've got rare conditions, one country is not enough, even if it's got quite a big population. So we find that you really need to combine data sets to really get good information that has statistical significance. The other thing that's really important with the registry is that with time, with more and more data, we can start to do what we call informed therapeutic goods allocation and service provision within our Australian country here. So, for example, as Michelle's saying, if you've got a drug that we want to bring to Australia that a trial has shown to be effective, the government wants to know, of course, when it gets to the PBS stage, how much is this going to cost? How many patients are there with Duchenne muscular dystrophy in Australia? Where are they? How are we going to plan for that? And then when we think about service provision, I'm sure you all know about the NDIS and being able to show where the challenges are, where are the care gaps. We have these beautiful Duchenne care guidelines that Ian has talked about, but is that actually achievable? Can some people achieve it and some people can't? And for those that can't, why can't they do it? Is that because of where they live? The state they live in? Are there certain care gaps that we can start to point out and show to the government that we need to be able to cover all bases? It's really important for attracting clinical trials to Australia, and I'll talk about that a little later on. And also post-marketing surveillance. So after a drug has come to the market, so it's available in Australia, it's really important to see what happens in the real world and what happens over many, many years rather than, for example, the year or two of a clinical trial. So this is the TREAT-NMD Global Registry Network. It's now got, I think, up to 70 or 71 member registries. It really covers a large part of the globe. And we have, like thousands and hundreds of thousands of patients and data sets that we can work with. And so it's a really, really powerful resource. And so for us, how do you go into the registry? So we have very broad inclusion criteria in stark comparison to a clinical trial, actually. So we welcome any children or adults with genetically confirmed neuromuscular disorders who live in Australia. There are specific ones we target at the moment, but increasingly broadening that as we get more staff and capacity. We also have said that deceased individuals are eligible, and that's really interesting because there are a number of families that reach out after their loved one has passed from the neuromuscular condition, and they found it a really valuable way to contribute to the data and have their family member remembered. And you can see here that this started in 2020 at the Murdoch Children's Research Institute, and we've had a accrual of nearly 1,000 participants into the registry. And now we are Victorian based. We're based at the Royal Children's Hospital. So when we look at what happens by state, as you can expect, because we do have someone on the ground in Victoria at our site, the children's, that the large majority of recruitment is in Victoria, and other states as well obviously contribute, but to a lesser degree. So we're always looking for ways to try and even this out across the country. And you can see here the Duchenne and Becker cohort are actually by far the largest group of patients in our registry, being one of the more common neuromuscular conditions that we see in our clinics. So I'm just going to give you an example of what sort of data we can pull from the registry and what use that might have. So you've heard about exon skipping agents. So we can look in our data set because we record genetic mutations for individual participants in the registry, and we can see who might be amenable to different exon skipping agents. So then, for example, if one of the companies that's making an exon 51 skipper, they can approach us, or they can approach sometimes Treat NMD so that they can get an international idea of how many patients are in specific countries with patients with Duchenne muscular dystrophy who have exon 51 skippable mutations. And then they will see, and this will be part of what they look at when they're thinking about what countries to approach when they're doing feasibility and site selection for clinical trials. We heard a lot about corticosteroids from Ian, so we've also had a look in our registry what the pattern of corticosteroid use is. So this is just an example of looking at different age cohorts and seeing who's taking corticosteroids, who's never taken corticosteroids, and who've come off corticosteroids having previously been on corticosteroids. We can look at how many percentage of patients take prednisolone compared to deflazacort. There's a very small number of patients who are in clinical trials on vamorolone. So we can see all this data. We can see who takes daily steroids, we can see who takes intermittent steroids, and so forth. So just really interesting to see what our pattern of practice is, what our colleagues are doing in other states of Australia, and to compare to what is done in the rest of the world. And we can also compare to what the Duchenne care guidelines also suggest. And then with time, because we do contact families once a year to collect data longitudinally, we can start to make these sorts of data sets where we can see what happens over time. TUG is time to get up off the floor, the North Star, which you also heard Ian mention. So we can see the trajectory and see how that compares to other publications and what happens in other international centres. So this is where I just wanted to focus a little bit on clinical trials and getting new drugs into practice. You just heard Michelle talk about the process of trials, from becoming a trial site to all the way, how do you get this drug so that my doctor can prescribe it for me for my child? And so as you've heard, the importance of what clinical trials do in terms of bringing drugs into clinical practice. And recruitment is very challenging when you've got rare diseases, and particularly in ultra rare conditions, which is what a lot of neuromuscular conditions we see are. And so registries are really useful to understand how many patients with a particular condition or particular type of gene mutation, or patients that may be amenable to a particular type of exon skipper, how many there are in a particular country, and how many in particular regions when they're trying to choose trial sites or come to a country or not. So registries are really, really handy to attract clinical trials. Through the Treat NMD network, we do often see calls for data from pharmaceutical companies who've clearly got a drug in development, and they want to know, and they ask the question internationally, can you all provide some information on how many patients you have in your country, in your registry, with this condition or this condition with this type of mutation? And then we can provide that, and they can get an international view of what's going on with a particular drug that they have developed. In some cases, registries can be also used for pre-screening or enrolment. With our registry, we do have the capacity, if patients are consented to do so, for us to contact their treating doctor if we become aware of a clinical trial that may be relevant to them. And so that will be information passed on to their treating neurologist, for example. The other thing, which is the next phase that you heard from Michelle, is going through regulatory approval, and then the buck is finally, who's going to pay the money for this drug? Who's going to pay $3 million for gene therapy for boys with Duchenne muscular dystrophy in Australia? And when you get to that point, it's really important to be able to give some idea of how many patients they are, where they live. You've heard about how complex giving gene therapy may be, trying to understand the logistics of giving gene therapy to multiple patients with Duchenne muscular dystrophy who all may live in the country or live in metropolitan areas, and the differences in how you manage that from a logistical perspective is actually really important. And this is across the board for all advanced therapies. And then after some of these complex drugs are approved, the government actually does require this thing called post-marketing surveillance, and particularly so for gene therapies, where because it's a gene therapy and it's so permanent and there are so many associated potential side effects, some of which we don't know and may not know for many years, it is a requirement for most governments, I would imagine, in most countries who are providing funding for these drugs to know what is happening in the long term in terms of effectiveness, but also safety and any unusual side effects that may only become apparent after many years. So just in the interest of time, I think I might just finish up, but just to say that's lots of things that we look at within the registry to try and improve what information we can get, looking at linking into other data sets, and linking into other research projects as well. And so finally, how do you join the registry? We have a website. You can click on this little thing in the top right and this thing will come up. You just enter your name, your phone number and your email address. Write us a little message. Hi, my son has recently been diagnosed with Duchenne. I'm interested in hearing about the registry. And of course, thank you to Alyssa, we have a QR code that you can scan. And I don't know how to make this, so thank you to Alyssa who made this. I'm technically challenged. And if you want to contact us there, our email, website and phone number are also available. And we're always very grateful to our partners and funding support. We have an advisory committee, which includes people from around Australia and our staff, and of course, all our patients and families who bear with us when we try and contact them once a year to collect some information. And that's it from me. Thank you, Kathy.
Amazing, Eppie. I was going to say, you definitely challenged the thought that registries are boring. I, for one, am very motivated when it comes to our registry and building our data recruitment. Something I never thought I'd say, but I am very interested and very motivated about that. So if anyone's on this call tonight, if you're unsure if you're on the registry or if you know that you're not on the registry, please reach out to Eppie and Melissa as soon as possible, especially Queensland and New South Wales. We can get those data sets up. So that's been awesome. Thank you. In terms of questions, we've had a few people email through more mutation-specific questions. So we just want to say, please ask your specific neurologist and let them know to reach out to Ian or Michelle if they have any further information or advice if required. But I think with 2 minutes to go, we'll wrap tonight. I just had one final thought that we just wanted to leave you guys with. So we understand that for many families, the access to these clinical trials feel like the ultimate goal. So as parents, we all want to do everything we can for our children, but we want to gently remind you that a trial So we want to gently remind everyone that the pursuit of a clinical trial should never come at the expense of your mental health and your family's well-being or your financial security. Ian, did you want to say something?
Yes, but I didn't want to interrupt you because I totally agree with what you're saying. I just wanted to say that if you are not based in Melbourne or Sydney, it can feel that it's there's inequity and it is unfair, and we are very much aware of that. Sometimes the logistics of the individual clinical trial do make it hard for people living in a different state to access the clinical trials in either Melbourne or Sydney. Sometimes it doesn't. So what we would suggest is that you talk to, if there's a particular clinical trial that is running in Melbourne and Sydney, and you're not living there, you talk to your individual neurologist and talk to them about the fact that you would like to know more information. I hope I speak for Michelle as well. I'm sure I do, but we'd be very happy to talk to people about it, individual specific clinical trials. But it really has to be with the agreement of your treating neurologist, and if we can make it work, then we will certainly try our hardest to do so. But it has to be in conjunction with your local treating team.
Yeah, absolutely. And we do need to weigh up all of the external values as well. So, being close to home, and, family support and all that, those logistics as well. So it's a really complex decision, and just being educated and just staying in touch with your clinical team and making sure that you're getting all the right information. So I guess, yeah, we just want to reinforce that you just need to be building your strong relationship with your treating clinicians, and trusting their expertise, following those Duchenne standards of care. Obviously, that remains one of the most powerful things you can do whilst we wait for these therapies to come, and progress through the clinical trial pathways. We know that, the feelings of frustration, feeling overwhelmed and exhausted, trying to keep up with all the with everything and all the information that's coming through globally. We just want everyone to know that you are not alone. We encourage you to speak with your neuromuscular team and those around you. They know your child best, and are happy to support you through these decisions. If you'd simply like to talk with other parents who understand the emotional roller coaster that Duchenne can bring, please reach out to us at Duchenne Australia. We're all parents and family members of children living with Duchenne. You've got our email addresses. And I guess, unless there's anything else, we just want to, as a final note, we know that hope is incredibly important, but so is protecting yourselves and your families. The emotional energy that Duchenne demands of us, that can be intense, and it's okay to acknowledge that. So sometimes the most valuable thing we can do is focus on what we can control today while continuing to advocate for a better tomorrow. So thank you once again to our incredible speakers, Dr. Michelle Lorentzos, Dr. Ian Woodcock, and Dr. Eppie, and thank you for staying so late. It's nearly my bedtime, but thank you so much for sharing your expertise and giving up your time this evening. And thank you to all the families that have joined us. Your resilience and your commitment to your children continue to drive progress here in Australia. So with that, have a wonderful evening, and we will look forward to seeing you at the next webinar. Good night, everyone.
Thanks, Kathy. Good night, everybody.
Thank you.
Thanks. Good night.